Good afternoon, my lady. If I may call Jill Walton, who will affirm.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Miss Walton, you should have your witness statement in front of you. That is INQ 303474111. Miss Walton, you're here today to give evidence on behalf of the Royal College of Midwives and its members, is that right?
That's right.
And you hold the role of Chief Executive and General Secretary, a role you've held since September 2017.
That's correct.
And you also have been a midwife since 1987, and prior to joining the college, you had midwifery experience in the NHS, is that right?
That's right.
And it's correct that the Royal College of Midwives is a trade union and professional association across the UK?
That's correct.
And can you give us an idea of the size of the team that work within the college?
So the Royal College of Midwives has got 100 staff, and we work across all 4 countries of the UK and actually also the Channel Islands as well.
Thank you. My questions today are going to focus on the role of the Royal College during the pandemic, then go through the maternity journey, as it were, with focus on the provision of maternity care and visiting restrictions, and then to look at the categorisation of pregnant women as clinically vulnerable, IPC measures, and then mental health and wellbeing support and the impact of long COVID on the midwifery workforce. So starting then with the role of the college in formulating and issuing guidance for the maternity sector during the pandemic. Is it right that outside of the pandemic, the college had a role in producing guidance and worked with the Royal College of Obstetrics and Gynecology to do so?
We did. In fact, the guidance, we were quite separate in terms, before the COVID pandemic, we produced guidance quite separately as 2 organisations. The pandemic actually brought us together to produce guidance and with other organisations. So it was different. It's something we started almost immediately. The pandemic, even before lockdown, actually, we got together and said we really need to do something about providing advice and guidance. We're quite different from the Royal College of Obstetricians and Gynecologists and other medical Royal Colleges because we don't produce educational standards. It is just guidance and advice, and that misunderstanding is quite. It's difficult at times because we can't hold our members or the organisations they work into account in terms of you must do this. It is just guidance that then is accepted by the NHS or the organisations that our members work in. So we're very different.
So who does provide the, sorry to interrupt you, who does provide the educational standards for midwives?
So that's the Nursing and Midwifery Council, provides standards and proficiencies for midwifery.
And in terms of the clinical guidance that was available for maternity services before the pandemic, is it right that that was produced by the maternity services themselves, so local protocols and NICE guidelines? That
is correct, and NHS England to some extent as well.
And is it right that the Royal College of Obs and Gynae and the Royal College of Midwives and the Royal College of Paediatric Child Health all took the lead together, as you've mentioned, on developing guidance on managing COVID in pregnancy?
Yes, we did, because we realised that clinicians working in services would need some help and guidance. And for the Royal College of Midwives, we became very focused on that piece of work and basically stopped business as usual in order to do that. We felt it was essential to be as helpful as we possibly could be for clinicians and hopefully for the NHS in terms of then adopting that guidance.
And were you asked to take on that role, or was that a role that just naturally happened?
No, we weren't asked to take on that role. We at the beginning, we took it on as we thought it was the most useful thing that we could do as a collective team.
And is it right that the Royal College of Midwives and the Royal College of Obs and Gynae set up a guidance cell, which initially was meeting daily in order to develop the guidance?
Yes, so we set up the guidance cell with the appropriate people on there, people who had a background maybe in research or clinical practice, expert clinical practice. They called in other people when they needed it, depending on what guideline they were looking at. I think the COVID cell was daily. I can honestly say that myself and Eddie Morris, who was the president of the RCOG at the time, spoke not daily, sometimes several times a day, so that we could try and be on top of the constant changing nature of the pandemic, the COVID virus, and people's understanding of it. So we tried really hard to make sure that the guidelines and the advice that we were given was as up to date as it possibly could be.
And on that very point, it's right, isn't it, that the first published guidance on pregnancy during COVID was published on the 9th of March 2020, and there were a further 4 updates in that month to that piece of guidance.
That's absolutely correct. And you will see with the amount of guidance that was produced by both jointly and us as an organisation ourselves, we had guidance that we constantly reviewed, updated, rewrote and republished all the way through the pandemic. It became one of the biggest things we did. The joint guidance that came from the cell, it was purple in colour, we joined our colours, actually was used all the way around the world. It was recognised as a really good resource on COVID, and it was the access on the websites was well in the millions, which was encouraging. And I can say that, you know, we were proud of that work, and we were hoping that it was going to be helpful.
And is it right that there were other advisory groups that the Royal College of Midwives set up during the pandemic?
Yes, so we had an internal professional advisory group. So that was looking at things that particularly for midwives, so the things that midwives would only be doing. So, for example, home births. We also used midwifery professors to do various bits of guidance. They often, when we've used professors in the past, on guidance, it takes years. You know, a piece of guidance or some advice can take years and years. Everybody was doing things really quickly. We knew that it may not be perfect, and we had to accept that. We had to do something as quickly as we could to be as helpful as possible, and then review it and change if it then turned out not to be right. We thought that was really important, rather than spend weeks and months, you know, making sure that something is absolutely perfect.
Looking to the future, do you think it would be helpful if guidance was available or had been prepared in advance so that it could be used if there were another pandemic? Obviously, as you've said, there did need to be updates and changes to it, but if that was standing there ready, do you think that would be helpful?
I think that it would be helpful to have a framework for guidance that could be used in a future pandemic. I think the most important thing is that it's everybody who's involved in delivering maternity services, for example. So, you know, the Department of Health with their maternity team, NHS in all the countries, the colleges that are all involved in delivering maternity and neonatal care, coming together with a single version of the truth, and doing as much of that as you can. Obviously, you never know what particular strain of virus that you're dealing with, so it would have to be developed at the time. But there's definitely something about making sure that women and families get really clear advice, and the staff delivering care get really clear advice, and everybody is saying the same thing.
And it's right, isn't it, that the college also set up a helpline in response to the pandemic. Can you provide some examples of the type of matters that was that they dealt with, and who it was staffed by?
So we had a helpline for both our members and for the public, and so then the RCOG, and we staffed it with clinicians. We wouldn't normally provide that service as the Royal College of Midwives to members of the public. that isn't actually our role, but we realised that there was a lot of confusion in terms of information advice to women, and so we decided that it was helpful for local clinicians caring for women, that if we could give some very clear advice, that would be helpful to them. We also, as part of the guidance we were producing, often had a page that was for information for women that midwives could use. So not necessarily direct to women, but could be used in a conversation with women in their care. And again, we thought that was helpful and maybe clarify some confusion. The sort of calls we often got from women were about visiting, about availability of home births, you know, particularly when they were really frightened, and just having some clarification about the impact of the virus on pregnancy was definitely something that they wanted to know.
And you've said in your statement that from the outset, the Royal College of Midwives and the Royal College of Obs and Gynae were clear that it was vital to maintain all aspects of safe maternity care, designate it as an essential service, particularly in the context of serious pre-existing staffing shortages. Can you briefly describe what the pre-existing staffing shortages in maternity services going into the pandemic were?
So there'd been a shortage in midwives and obstetricians and other members of the maternity team over many years, and we anticipated that shortage to be between 1,500 2,500. It's difficult to know exactly, and that gap wasn't closing. So basically, we went into the pandemic with already a shortage of midwives and the maternity team, which was already having an impact on the quality and safety of care.
And is it correct that on the 7th of April, following a meeting that the college had with the chief midwifery officers of the 4 nations, the college were provided with reassurance that, in fact, maternity services would be prioritised?
Yes, so we had brought it up as an issue because we had lots of connection with our members, particularly the Royal College of Midwives, because we're also a trade union. So we have a branch structure, and we have our Royal College of Midwives members who run branches in local services. We had loads of meetings with midwifery leaders. We were very in touch with the front line. And one of the things that we were really concerned about is that maternity services weren't seen as an essential service locally and potentially nationally, and that was having a major impact on the ability to deliver safe care, because the focus was really on intensive care units, respiratory areas and emergency departments, and maternity is an essential service. You can't stop it. Delivering that safe care is absolutely a priority for any NHS service. So we called that meeting in April and said we really needed to be, it needs to be a guarantee that all NHS services recognised that maternity was essential. So, for example, there were definitely issues where some midwives who were duly qualified, so there were nurses and midwives, maybe then redeployed to an intensive care unit or a gynaecology unit, and then depleted that midwifery staffing even further. Anaesthetists were definitely an issue. They were also redeployed, which then led to issues around being able to provide safe epidural services. So there were lots of examples that were raised with us as a huge concern and a huge anxiety amongst the staff, but also in terms of the women as well accessing care.
Thank you.
I'll ask you to speak more slowly.
Yes, certainly.
We're going to come on to look at some of those examples you've just given in more detail. If I can move on then to the topic of antenatal care during the pandemic. Guidance was produced by the Royal College of Obs and Gynae on the 23rd of March 2020, which advised a minimum of 6 face-to-face antenatal consultations and 3 postnatal contacts, with the option for video and remote as an alternative, and included guidance on how to risk assess and prioritise services in the event of staff shortages. How did that advice differ to before the pandemic?
So before the pandemic, there was a minimum of 10 antenatal contacts, slightly different between first-time and second-time mums. That's a very basic. If women have comorbidities or need additional care. So, for example, if they had an obstetric problem, they may be seen far more than that. Postnatally, there's not really a minimum, but it must be a minimum of 3, potentially 4. And again, if women in the postnatal period have particular problems and need more support, then obviously there's many more visits than that normally.
And in the college's experience, was that advice followed?
Actually, I would say that midwives tried really hard to maintain their face-to-face contact because they felt it was so important. They were anxious that they weren't doing that. There were occasions when they couldn't because they didn't have enough staff. What was reported to us was that, in fact, when they started to do online and telephone contact, some women ended up with more contacts than they had previously because that wasn't a system that they had used. So they certainly prioritised more contacts for women who were anxious, had complications, had COVID. You know, there was definitely an increase in contact, but not necessarily face-to-face.
And the college produced guidance in July 2020 for the use of virtual consultations. Was there any guidance available before July?
No, I think there was some loose conversations about virtual consultations, but we realised that there were different techniques being used around the country, which was causing confusion. So that's why we did that guidance.
And was there any analysis carried out of the impact of that immediate rollout of virtual antenatal and postnatal appointments to ensure that pregnant women did continue to get the level of safe care that they needed?
Are you referring to our survey?
Yes.
Yes, so we did a very quick survey to make sure that that midwives were using the guidance and continuing to provide as much care to women as they could with the backdrop of actually having a much reduced staffing. Also, there were real issues about delivering community services with a lack of PPE, not knowing whether the people you were caring for had COVID or not. So there was an anxiety amongst the staff about caring for women in a face-to-face setting, in a community setting, particularly in somebody's home. So we could see that the telephone and video contact was being used, maybe more than we anticipated, because it helped the anxiety of going into the unknown and visiting people in their own home.
And were you aware of there being any drawbacks to that, for example, digital exclusion or access to equipment?
Yes, that was reported to us. So we realised that some women didn't have access to a phone or an iPad or a computer, and also for women whose first language wasn't English. I think a lot of services picked that up as issues and tried really hard to prioritise those women for more face-to-face contacts, but that took a while to get in. But that definitely was an issue.
Thank you. I want to have a look at a graph with you. This is INQ 304855652. Thank you. And this relates to antenatal scans in England before the pandemic, but also during the relevant period as well. And we can see from this graph that there was a drop in non-routine antenatal scans and routine, antenatal scans. During wave 1 and wave 2 of the pandemic. Can you briefly explain why those scans are so important and the potential impact of there being a decline?
So some of the scans, the routine scans are at 12 weeks and 20 weeks. They really are important to make sure everything is fine with the pregnancy, with the baby. There was a reduction in women accessing those scans. Some of it, I think, was because they couldn't take their partner or they were worried about coming into a hospital environment. So the stay-at-home message definitely impacted on pregnant women at that time. I think the non-routine scans, that's checking for babies who may not be growing properly, babies that may not be moving properly. They did reduce, and some of that wasn't because women weren't coming for the scans. My understanding from our members was that some of the women hadn't reported that they had a concern. And there was definitely some confusion around accessing maternity services because the message was stay at home. Our message was very much maternity services are open. I certainly went out in the media myself and said that many times because we were really worried that women would be frightened, they'd stay at home, and that something might then happen to them or their baby because they weren't accessing appropriate care. And I think that might be what that graph is telling us.
Thank you. That can come down now. Thank you. And there was guidance from the Royal College of Obs and Gynae on telephone triage in relation to the non-routine antenatal scans. So if there were concerns, if a woman had concerns, and whether a scan or consultation was needed straight away or there could be a safe delay. Was the College of Midwives aware of any training or guidance for that move to telephone triage that was published?
I'm not really aware of any local training. Obviously, we had our guidance, and because it was guidance and not necessarily enforced, it would be up to NHS England and local organisations to adopt that guidance locally and put in the training for it. So I can't answer in terms of what happens in every single organisation. And my hope would be that if something was going to be done differently, like telephone triage, that there would be training for the staff that were going to be doing that.
And you've touched on the stay-at-home messaging, but in the college's experience, was there an impact caused by the reduced access to primary care, so GP services as well?
Yes, I think the stay-at-home message impacted women accessing primary care, midwifery care and coming into hospital. I think there was a lot of anxiety around, particularly when women were classed as vulnerable, and that absolutely impacted on access to appropriate maternity care.
I want to ask you some questions about the visiting guidance in antenatal settings. We've heard quite a lot of evidence about this already, but the Royal College did issue a briefing in July 2020 on the reintroduction of visitors to maternity units across the UK. You've summarised that paragraph 35 of your statement. Can you just explain what that briefing included?
So after the first lockdown, where access to NHS services there was almost a blanket ban on visitors, and we definitely were part of the advice to at least let partners in during labour for women. That was absolutely important. The issue about opening up, so the visiting opening up, and absolutely, it was such a stressful time for women and families, for the staff who were looking after them. Staff didn't want to tell people they couldn't have their partners with them during the whole maternity experience because that isn't what midwives do. But they were working in difficult environments, tiny spaces, really difficult to have a socially distanced care. There was a shortage of PPE still, and so bringing more people into inappropriate environments was really difficult for lots of services, and midwives were really worried about the impact on increasing infection for the staff, but for the women and families and the babies that were in the services. So opening up the visiting was a really difficult thing for people to do. They really wanted to do it, but the practicalities of doing it was a different story. I think the other thing that happens at the time, we have some really great maternity services around the country that are very new, have single rooms where women and their partners can stay practically their whole stay in the maternity service. those services did really well in terms of being able to open up. But those services that didn't have those sorts of environments really struggled. So, for example, in antenatal clinics, there were some that were co-located with gynecology services or gynecology cancer services, and then there were also pregnant women with their partners. You know, it was very difficult to create a safe environment for opening up a maternity service to what was happening before.
So if I could just bring you back to the question of this briefing in July, what led to the college producing guidance on reintroducing visiting at that point in time?
We just wanted to make sure that it could be managed appropriately. We would have hoped that NHS England would put out very clear guidelines for opening up that could be then localised, but that wasn't happening, which is why...
we're going to come on to that in a moment.
Okay.
That specific example that I think you're talking about. Okay, so at that point in time in July, it's right, isn't it, that the guidance across the UK was quite varied as to whether services were opening up, visiting or not?
Yes. And also they were localised, there were different lockdowns in different parts of the country,
yes,
and I think that caused huge confusion. And social media didn't help. I think, you know, it was on social media, there were different stories in different parts of the country, and then, you know, people jumped on that bandwagon and created some more confusion. Social media didn't help what should we do? What's the important thing for the NHS to do? How do you keep staff and women and babies safe? And how do you do this in a clear, logical way? And while that was being sorted, of course, the infection rate started to go up again. So some services hadn't even managed to open up hardly at all before we knew that there was an increase in infection rates.
And you've spoken there to the inconsistencies and variation across services, so not just across the UK, but across services as well, as to whether the guidance was in fact implemented or followed. What impact did that have, not only on pregnant women, but on healthcare workers in those settings as well?
Well, I think it made people very anxious because at the time, I think NHS England were praising those services that were opening up, and some could, and then being quite critical and putting targets on services that couldn't open up, and they're giving them deadlines to open up. And I think that caused a huge anxiety. And we had lots of meetings with midwifery leaders who expressed how difficult it was to keep thinking about the safety of women and families and their staff in quite often poor environments that they were working in, and they couldn't see how they could completely open up services safely.
Who would be responsible in a hospital or maternity unit for implementing the guidance actually on the ground? Do you know?
So in the maternity service itself, it would be the director or head of midwifery who would really know their service, but the infection control teams in a trust would absolutely have a view on that. And I think sometimes I remember some of the heads of midwifery, directors of midwifery, saying to us that there was a change in policy, and the infection control departments were putting in processes for opening up, but actually the midwives themselves were saying, but actually I'm not sure this is going to work. We've got a very small, for example, 4-bedded postnatal ward where the beds are really close together. There's 4 mums, there's 4 babies, and then we have mum and dad and maybe grandma as well. That is a huge infection risk, and not being able to distance. So there were lots of pressures, and I know from speaking to our members around that time, their anxiety levels were huge. They could see that, you know, the country seemed to be opening up, but infection rates were starting to pick up again, and they were thinking of ways of preventing harm. So it created a huge anxiety for the staff and for the women.
And a lot of the guidance around this time in July 2020 in the summer moved to local risk assessments and a local approach. Was there support, I suppose, and advice for how to undertake those kind of local risk assessments in the context of COVID-19? From the
NHS, I think that some of that advice was quite limited. Because we're also a trade union, our health and safety activists in those services were helpful, and we provided them with some support and guidance for that. So I think we were quite lucky in that because we're a trade union, we could also provide support and guidance to people locally. But I think this was a bit of a theme. There was slow information coming into services for local services then to do the right thing.
Was there enough information about the rationale for the changes to the guidance for healthcare workers that were implementing it, but also for pregnant women as well who were?
I think, as I said before, I think it was very confused.
Did the college take any view on parents being designated as visitors in maternity settings?
Actually, they shouldn't be visitors. Our view was that they're equal partners, parents of the baby. But we absolutely recognise the difficulty in having, additional people in some areas within some hospitals and the risk that potentially that caused. It was horrible. It was horrible for those parents. It was awful for the staff because they didn't want to do it either. Midwives absolutely see parents as both parents of the baby, even though the mother's the one having the baby. And I think it caused a lot of stress for them. I think the guidance created some friction sometimes between the staff and the parents because of course they wanted to be there and it was right, but actually there was still a risk, and that caused some really difficult moments, I think, in maternity services and on social media.
And does the college see that there would be any merit in having, for example, a national framework for visiting, perhaps with an element specific for maternity settings, to ensure that there was consistency, predictability, but also that support as well for those that are having to deliver the news, that there be restrictions?
Yes, and I think that would be, a recommendation going forward, a single truth, but with a framework that has to come from NHS England, not from the colleges, that give people a framework in which to assess their services and localise them if necessary. But the most important thing, that is then transcribed into really clear communication to the local population, so everybody is clear what that service is doing and why. For that reassurance, I think I've mentioned social media before because I think social media created some confusion itself, because different services talked about what they were doing and how unfair it was that service down the road wasn't doing it, and it didn't help the anxiety between groups of parents and staff, and it made people angry. It made parents angry, which I absolutely understand.
And you've said in your statement that the extent of the guidance that the Royal College of Midwives provided was an indictment of the lack of guidance and leadership provided by central government and NHS England. And we're going to come on to look at a specific example of that in a moment. But was that also the case across Scotland, Wales and Northern Ireland?
Scotland, Wales and Northern Ireland, it was different because they're such small countries. And I can talk from the Royal College of Midwives perspective. The midwives in the government and the senior midwives in the NHS in those countries and the RCM all knew each other. And they had worked really closely together in the past, and they sat down and worked it out together, probably more than England. Different countries did things at different times, and I can't remember what all of those things were, but they did visiting restriction. They lifted visiting restrictions at different times. They had different rules, and that caused the confusion. But I do think that the way the other countries managed it was clearer for both the public and the staff working in the services.
So if we were to look forward to having some form of national framework, would you support that being across the UK?
Yeah, definitely, because different countries would look at each other and say, well, it's, in Scotland, visiting's been lifted. That's not fair for England, and then, creates that anxiety amongst women and staff.
So moving on then to a specific example where the College the Royal College of Midwives and the Royal College of Obs and Gynae took action in response to guidance and visiting guidance specifically. In England, if we could please go to INQ 302805803. And at the bottom, this is an email, from Mr. Morris from the Royal College of Obs and Gynae, sending to NHS England with you CC'd in on the 10th of July 2020. So again, around this time that we're talking about the changes in guidance. And in that last paragraph there on page 1, he has said that while we understand restrictions on visitors remain in place in some trusts in England to ensure compliance with social distancing measures and prevent the spread of coronavirus, we think it's vitally important that NHS England urgently produce a framework or set of principles to enable trusts to take a consistent approach to the relaxing of outpatient and inpatient visiting restrictions on maternity units. And there needs to be a reasonable balance between continuing to protect women and staff from in-hospital transmission and enabling vital support at appointments during induction of labour and from visitors and post-natal wards. And if we go up, we can see the response that in fact comes from NHS England the following day. And that is the second paragraph. Thank you. You will no doubt appreciate that we cannot address this issue within maternity in isolation, notwithstanding the particular need women have for support during maternity appointments, and we're operating within a fixed set of parameters, including in particular the decision that there will be no relaxation of the 2-metre social distancing rule in hospitals in England. What was the college's response to that response?
If I remember correctly, we wanted NHS England to not have a blanket approach for all NHS services and have maternity as a separate consideration, but bearing in mind that there would still have to be a consideration about keeping everybody safe. But I think that the key issue about these emails was about the lack of response. It was taking a long time to sort out a growing concerning issue around visiting and the inconsistencies and how unhappy women and families were and the staff were about not having clear guidance. So I think we were trying to ask very clearly that NHS England had to put in a much clearer, consistent framework, so that that everybody knew what they should be doing, because the confusion was causing more stress, and particularly for women, it's a very stressful time having a baby. Having a baby in a pandemic with inconsistent guidelines is even worse, and staff then not being able to be really clear themselves about this is what we're doing, this is why, this is when it will start or end. It was very unclear.
And is it right that around this time, both colleges had actually been working with NHS England to produce guidance, but there was a delay? I think it's until the 8th of September when the guidance is actually issued by NHS England. Is that right?
That's correct. And I think it was a general, looking again at recommendations, that if everybody's working together to produce guidance, how is the red tape removed in terms of getting them through various processes to get that guidance out quickly? Because I think we were working really hard and really quickly to produce guidance that was asked of us by clinicians in services, and we couldn't endorse it. It was almost a gift to the NHS to say, look, we've done all this work. it needs to go out. And I think there were delays, and this was absolutely one of them, where if that guidance had come out even 3-4 weeks earlier, then the upset, the harm, the anxiety may have been reduced just over that period of time.
The guidance that was produced in September was a framework to reintroduce access for partners, visitors and supporters of pregnant women in England, and focused on local risk assessments and regular reviews, with a look towards parents being considered essential visitors. Did the college agree with the approach towards local risk assessments at that time, and did it endorse that guidance?
We did endorse that guidance, but my memory is that we felt anxious about the local risk assessments because, again, services that could accommodate easily and safely women and their partners could have a risk assessment that would say, yeah, this is fine, and then others would really struggle with that. So we were anxious about it.
And were you aware of any issues that trusts had implementing that guidance?
My understanding was that they were concerns, and they were trying to feed that back. They fed that back through us and then directly to NHS England. There was an issue, I think, at the time and it goes back to maternity services sometimes being the forgotten service in the NHS, and where midwifery leaders don't have a voice at the board, for example. So when there were local issues, some midwifery leaders struggled to have their voices heard in terms of, we're struggling with this, we need some help, we can't do this. I think there was definitely some tension there about how maternity services are structured within the NHS, and it's very difficult to raise issues appropriately.
Were there any changes to the guidance in response to those concerns that you've just mentioned?
I think so. Have I got that in my statement? You have to refer.
I think the next changes to the guidance, in fact, are in December.
That's right.
Yes, so September.
So it took till December. And I think you'll find in some of the evidence lots of email exchanges and conversations. There are lots of conversations that obviously aren't recorded.
In December, the guidance from NHS England was that a woman should be supported by another person throughout the pregnancy journey. So it moved away from that local risk assessment approach and encouraged units to change the layout and to ensure there was regular testing. Again, is it right that the college had some concerns about increased attendance at that particular time?
We definitely did, because the gap between September and December was too long. And obviously by December, the infection rates we had a new variant of the virus. Infection rates were increasing. And so increasing the numbers of people walking into maternity services was increasing the risk for mothers, babies, the staff. And so we were very worried about, staff were very worried about that. And again, I think it's about acting quickly. It's about, I suppose it's about predicting that, absolutely right in the summer, visiting guidance starting to open up by December. If there wasn't going to be an increase in infection, yes, let's start encouraging services to have partners available throughout the whole maternity journey. But we had another strain and infection rates going up again, and nervousness about, will the staff be impacted? Will they get infected? And in fact, staff did get the infections. They were sick. In some services, 40% were off sick. So it was a really difficult time in terms of December being the time to completely open up maternity services. There was an issue as well about testing. So testing came in around the same time, and it was so distressing for women and partners to come in, even into a labour ward setting, and partners to be tested and were positive even though they were unwell and not able then to come into the service. Obviously, women were asked to designate another person in case that happened, but that caused serious anxiety, concern, some really awful behaviour as well. And I absolutely understand that, but I know midwives really struggled at that time.
And it's right, isn't it, that the college didn't endorse that guidance in December, but in fact issued its own 10 common sense principles, which was focused on localised decision-making and risk assessments. What were the reasons, if there's any additional ones to those you've already given, to the college issuing those principles then?
So those principles actually came from our conversations with midwives on the ground, who were saying that they still need to have a framework that was based on the local services that were common sense principles that they could then communicate to women and families. So we thought, and they were mostly adopted then by NHS England, but they came from clinicians, they came from midwives and maternity support workers working in clinical services, and what they thought would be most helpful in keeping everybody safe.
And in the development of that guidance in December by NHS England, had the college sought to bring those principles to their attention?
Yes, we did, yeah.
Are you aware of why they couldn't support them at that time?
I think it was because they were still looking at a whole blanket NHS approach, and that they wanted to open up maternity services for all parents, because there was a lot of pressure from parent groups, rightly so, from the public, from the media, from politicians, from journalists. So I think NHS England, I can remember speaking to them, were under huge pressure to respond to that, but actually were maybe not thinking about the total risk of keeping staff safe and keeping women and babies safe. And it's a difficult decision to make when you're under that much pressure from external agencies. I get that. But actually, you know, we're a membership organisation. The staff were really important. If staff were sick or having to isolate, they can't look after women and families. And it was really important that we helped to try and get this right.
And do you know if those principles were used across the UK?
I think some services did use them, but again, we couldn't mandate them to be used. And NHS England, I think, did support some of them. So there was some leaning towards those principles being used, which was good. And certainly some of the midwifery leaders that we spoke to regularly really welcomed them and used them in their services.
And you've touched upon the college's communications with NHS England and the like in regard to the guidance. To your knowledge, was any consideration given to consulting with patient representative groups during the development of that guidance?
From NHS England?
Yes.
Yes, I think so. We also had a system in the Royal College of Midwives. We have with the Royal College of Obstetricians, we have something called One Voice, where we have parent and baby charities and the colleges together, where these issues could be discussed. So we certainly discussed the things within our guidance with parent groups, and we would encourage that locally as well with Maternity Voices partnerships and women. So we'd encourage midwifery leaders, for example, to discuss a local guidance or changes to guidance with their local groups. That's really key.
And did the college communicate with the chief nursing officers or chief midwifery officers in the Four Nations regarding the guidance? Yes,
we did, and we had lots of conversations about that. We did escalate in England. We did escalate some of the issues and the discrepancies we had and the length of time to Dame Ruth May, who was the chief nurse, and she was quite helpful in terms of unblocking the way with some of those issues.
You've touched upon the issue of testing to facilitate visiting in hospitals, and that came in certainly in England at the end of 2020 and in Wales in middle of 2021. could the introduction of IPC precautions, for example, testing and access to PPE earlier, have helped to facilitate visiting?
Absolutely. Definitely would. I mean, if there was PPE for visitors, for partners, for the staff, testing for everybody, it would reassure people that of the situation, you know, who they were looking after and what the risks might be. That absolutely would have made a massive difference. I mean, it's interesting, isn't it, that I'm not sure now whether the testing was available elsewhere in the NHS before it reached maternity, but I think there was an issue there. Again, maternity not being seen as, you know, a key part of NHS care, an essential service.
Thank you. I want to ask you one more question regarding support during antenatal services before moving on. If we could have on the screen, please, INQ 304744233. This is the Every Story Matters report that the inquiry has received. And the quotation here in regard to maternity services is that going through maternity services and giving birth when the NHS was crashing around me with added layers of having sight loss was hard. All information was paper-based. I couldn't see the sonogram and didn't have a partner there to explain things for me. I was full of anxiety. My sight loss wasn't accounted for. They were focused on navigating care in COVID. Reading out letters to me wasn't a priority. And that's from a woman who used maternity services during the pandemic. Are you aware of there being communication issues due to the restrictions on visitors and supporters during antenatal appointments and scans, and whether there was any guidance or support available to healthcare professionals for that?
Yeah, so we were producing guidance about prioritising services for vulnerable women, disabled women, women from a Black and Asian minority ethnic background, where we know that their experiences and outcomes were different. So this lady would be her experience. So absolutely, that was we really encouraged services to prioritise their care, which was important because their staffing was depleted. So you know, it was really important that whatever they could provide was to the people who really, really needed it, and they could improve their outcomes.
Thank you. That can come down. I want to move on then to birthing options and the changes during the pandemic. So we heard this morning about the different birthing options outside of a pandemic, being hospital, midwife-led units, whether freestanding or adjacent to a hospital, or a home birth. Is that right?
That's correct.
And it's right, isn't it, that the college, along with the Royal College of Obs and Gynae, issued guidance in April 2020 for midwife-led settings and home birth in the COVID pandemic, which set out a staged approach to support the continuation of home births and births in midwife-led settings, where staffing levels and ambulance capacity allowed, and then also set out a move towards centralisation of services with restrictions and suspensions of other birthing options, with reinstatement when it was safe to do so. Is that a fair summary of that guidance?
Yes, it was a toolkit to be able to maintain services if staffing levels allowed, including the ambulance service. So we were hoping that was going to create some helpful decision making and try and create some equality amongst services, because I think at the time some services, because their staffing levels were fine, were able to maintain a home birth service and others wouldn't, and that was creating competition really between services and making women feel that if they wanted a home birth, for example, they'd have to change to a different hospital, and it was unsatisfactory in terms of then provision of services.
If we could then, leads me on to my next point actually, which is some data that we've received from NHS England showing the closures and suspensions in April 2020. This is at INQ 304855652. This is data taken from England in April 2020 and across 130 trusts. You should be able to see that in front of you. Yeah. We can see here that there was, during that month, the suspension of home birth in 60 of those trusts. so just under 50%. A closure of, alongside midwifery units, there were 8 closures, 11 freestanding units were closed, and 2 obstetric service units were also closed. The closures that we can see there, are they examples of services essentially having to centralise, as you've set out in that toolkit?
Yes, basically in order to deliver safe care to all women with the depleted number of staff and access to ambulance services, the directors of midwifery use that to make sensible decisions about keeping all women safe. Midwives really support home births, and it was a hard thing for them to do. But a home birth takes 2 midwives, and that, when you haven't got enough staff, is difficult to do, where you don't have enough midwives even to provide one-to-one care to women who are maybe giving birth in a local hospital. I think it's testament to this that not every service closed their home birth. You know, they were really agile in terms of doing what they could based on their staffing numbers and availability of ambulances at any one time. And they always tried their best to reopen parts of the service if they could. I think, you know, locally, some services communicated that really well to the population. Other services may not have done. And we as a college really encourage good local communication with women about the status of service provision at any one time. That was really stressful for women, and you will see in some of my evidence that there was then an increase in free births because women really wanted a home birth. There wasn't staff available, so they gave birth without a health professional. Some of those women did because they were scared of going into hospital as well, but it definitely had an impact on, you know, women being able to access the service they wanted. But it was all done to keep services as safe as possible. That was always the intention, not to deprive people, women, of choice.
Thank you. We're going to look at some more data in a moment in regard to slightly later on in the pandemic, but I just want to stay in this early stage. It's right, isn't it, that the college made a plea at the end of March 2020 to ring-fence maternity services by stopping the redeployment of maternity staff?
Yes, we did, and we made that plea quite loud because we heard from our members that staff were being redeployed and it was having a serious impact on them being able to deliver safe maternity care. So, you know, that did happen. Staff were ring-fenced, although we still had people telling us that it wasn't consistent. And in fact, even moving into the next wave of the pandemic, sort of December, January time, NHS England were asked again to make it absolutely clear that maternity was an essential service and staff should not be redeployed. And that did happen.
Thank you. Were you aware of services having to use healthcare assistants or senior managers or other members of staff who were redeployed into maternity settings to support service delivery?
I'm not aware of from other services. I know some of our midwifery leaders that we met with regularly were working clinically because they had to, but they also had leadership responsibilities in terms of managing the services and making decisions. So I think that was quite difficult for them. Only midwives can, you know, it's you know, midwives. Nobody else can carry out the role of the midwife. That's actually illegal. So I'm not aware of others from other parts of the unit coming into maternity to work clinically, because that wouldn't be possible, which is why maternity services had to be ring-fenced. You can't take midwives out of maternity services to do other things because nobody else can replace them. That can't happen.
Thank you. Moving on then into June 2020, data from Scotland shows that of the 14 health boards there, only 2 of them at that period of time were offering the full suite of antenatal care. And a survey by the Royal College of Midwives in Scotland showed that their had been significant redeployment in the maternity services in Scotland. So were you aware of any action being taken to prevent redeployment, not just in England, but in Scotland, Wales and Northern Ireland as well, and whether that had any impact?
Yes, so the directors, the Royal College of Midwife directors in those countries, and I believe the RCOG as well, very rapidly asked for maternity services to be ring-fenced and redeployment not to happen. My understanding is that that did happen quite quickly.
Thank you. In terms of the guidance from the college after the first wave, you've described that a more nuanced and localised approach was required rather than a one-size-fits-all in your statement, and the college developed a set of service principles in May 2020. What was the focus of those principles during that period of time?
Can you just bring me to...
Yes, I believe it's paragraph 32 of your statement.
That's about visiting again.
Is it at 30? Yes, I beg your pardon, it's at 34. You've talked there about
so that was more,
that's all in terms of visiting?
It's all the same. Okay. No, that's not visiting. That's about ring fencing maternity staff. So by September 2020, all the groups we set up during the first wave, we knew that the infection rates were increasing. Mm-hmm. So we reconvened all our working groups, but we had to reiterate the ring fencing of maternity staff, and we published that as a press release so that it was out in the public domain, but also making sure that NHS leaders knew that how important that was.
Thank you. If we could have a look, please, at INQ 30485-652. Again, this is data from England on the closure and suspensions of home birth services, freestanding midwifery units, the alongside midwifery units and obstetric units. This is data that was collected from May 2020, as that's the date that the maternity services were formally included in the SITREP data in England. So we can see here that there is, again, a suspension, a number of suspensions of home birth services during the second wave. What was the guidance from the Royal College around that time for services to continue during that second wave?
So in the second wave, our guidance was the same. You know, it was the toolkit for making sure there was safe staffing, safe transfer of ambulances, so that all women could be kept safe, but to open up those services if they could, if staffing levels allowed. London had a particular issue during that time, being able to, be able to have enough staff to provide home birth as a choice, and so the choices were withdrawn, and we were really supporting our members to make those common sense decisions about making sure that there was enough staff in central places in order to care for the women as safely as they could. And it did reduce choice for women, it did, and that was a consequence of the pandemic and what was happening to the staffing levels.
Thank you. We can see also from this graph that from around June 2021 onwards, the closures and suspensions of services increases across almost all of the services in the options for birthing, the birthing options in England. What are the college's views on the reasons for this in the data?
I think some of it was that my understanding was that staffing levels hadn't improved. People were exhausted. The mental health of the staff was poor, and they were really struggling to provide very basic services. So to go to start opening up more complexity of a home birth service just didn't seem possible. And so it was easier to keep them shut than it was to reopen them. And I would say that was the safest thing to do. That would be our view. Keeping staff and women and families safe during this time was the most important thing. Even though it was difficult to give that message and it restricted women's choice, it did help maintain a level of safe services. Staffing levels at the end of the pandemic as well weren't just about current staffing levels. A lot of midwives, when the pandemic started, stayed. They might be retiring soon. Some of them had just retired and they came back. I think as we went into the second wave, a lot of midwives who were exhausted then left. So there was an increased staffing problem, not just sickness and isolation from the pandemic.
And to your knowledge, were those levels of closures pervasive across the UK, or was that an England problem?
It was across the UK, but I think England, there was a particular problem in London, definitely.
And ultimately, did you hear reports of that impacting on women's birthing options?
Yes, we did. And some of the women would phone the college. They would, comment on social media. And I absolutely understood where they were coming from. Women have one opportunity in that pregnancy and birth to have a good experience. And they were really disappointed, anxious, and it was a really difficult time for them and for the staff who were looking after them, because they didn't want that either, but they had to make safe decisions, and this is one of them. This is a decision they had to make, which we, tried to support.
Thank you. Moving on to the topic of miscarriages, were there any changes in the guidance on the management of miscarriages during the pandemic?
Obviously, in early pregnancy, miscarriage is not managed by midwives. Some women miscarry before they've even booked with the midwife. I think that the same applies to all of the maternity journey. At the beginning, it was the stay-at-home message caused some issues, and then access to services where keeping away from the NHS was part of the other story. I can't comment on gynaecology staffing issues or early pregnancy units because it's not a place where midwives normally work.
Thank you. In terms of pain relief, was the college made aware of examples of limited or delay access to pain relief, including water births, birthing pools or epidurals?
So at the beginning of the pandemic, it was in the first wave, when we weren't quite sure about the virus transmission. There were definitely issues about whether the virus could be transmitted in water. So there was restriction then on water birth. And I think our joint guidance with the RCOG did talk about restricting water birth, particularly if we were unknown of the virus status of the women, because we weren't testing. It changed because then it was an airborne virus, so water births were started to be provided in services again, and we again updated our guidance with that. The other issues were about anaesthetics and access to epidurals, and that was another reason for ring fencing staff. Anaesthetists were they were short of anaesthetists in ITUs, so the anaesthetists were redeployed away from obstetric services, so much, not completely, but there were less staff available. So having access to epidurals and quickly was a concern to midwives who were looking after the women.
Can I just ask about that? Sorry to interrupt you, but it's a subject we've touched on before, but if the anaesthetists are needed in intensive care units where people are dying, can one really object to redeployment of anaesthetists away from pain relief, much as obviously somebody in labour, a woman in labour, would like to have pain relief, of course. But I'm not sure that there's a comparison between pain relief and people dying and needing the services of an anaesthetist.
Yes, my lady, that's right. Apart from, there's not many anaesthetists available in a maternity unit. Usually there's only one. And they are needed for the emergency part of childbirth, so emergency cesarean sections, epidurals when there may need to be an operative delivery, and also women who collapse as part of, an unfortunate consequence of labour. Some women have a medical emergency. Most units have only 1 or 2 anaesthetists available at any one time, so having no anaesthetist was a huge risk. In terms of pain relief, there were other options for pain relief, and midwives would talk to women and offer all of those methods of pain relief if there wasn't an anaesthetist available. But, we had reports from women who were traumatised by not having access to an epidural for pain relief, not necessarily for an emergency caesarean section. So it was definitely an issue. There's not loads of anaesthetists and there's not lots in maternity units.
And really the answer to my question is it's going far beyond the pain relief, much as there are some women who are traumatised. The use of the anaesthetist for many other purposes other than just the epidural.
Absolutely it is.
Thank you.
I just want to touch briefly on one issue around the guidance on visitors and birthing partners around active labour, and the inquiry's heard some evidence around the definition of active labour within the guidance, or the lack thereof, and the interpretation of when a woman may be in active labour and therefore allowed to have a birthing partner attend. Did the college hear of any problems with interpreting active labour, and did it seek to raise any of those concerns?
Yes, and in fact it wasn't about the definition of active labour, it was much more about the environment in where women were being cared for in that first part of the pandemic, where partners could be there in labour. So quite often women who are induced or in early labour are not on a labour ward. They're in maybe a 4-bedded bay, so with other women. So that was more of the issue rather than definition of active labour. When women are in active labour and then require midwifery care, maybe requiring pain relief, extra monitoring, they then move to a labour ward, which was where we knew that partners could be. So it was about the environment is the main issue, because women in early labour are quite often not on a labour ward.
And did raising those issues lead to any changes in the guidance that you're aware of?
I'm not aware that it did, although there were lots of conversations about it, definitely. Thank
you. My lady, I am about to move on to a new topic. So
certainly, if I could just ask one question before we break. Sorry to cut across you, Sand. In relation to the guidance, I appreciate the Royal College was doing its very best to issue the guidance that its members so desperately wanted, especially in a fast-moving situation. I've heard a lot about guidance whilst conducting this inquiry, and how did the college go about trying to get the balance right between issuing the guidance that was needed, updating it when it was necessary, but not doing it so often and so much that the hard-pressed midwife who was trying to implement the guidance, understand it? I mean, there's a balance, isn't there, between issuing too much guidance and flooding the midwives with guidance and issuing the right amount. I mean, did the college analyse? I think at the beginning, Mrs. Hands talked to you about 4 updates in March. I mean, did the college analyse how you got that balance right?
We didn't analyse it, but we were told by our members that it was overwhelming at times, the amount of guidance that was being produced. But then it was a quickly changing situation, and we didn't want the guidance to be out of date that potentially might cause harm. So I don't think we had any choice. So we did try to balance it. I mean, sometimes we'd hear of an issue on a Monday and produce or analyse and change our guidance so it went out on a Friday. Certainly our members told us that constantly giving them new guidance on a Friday was really difficult for them. And we did take that on board and tried really hard not to send out guidance to them on a Friday. It is hard to get that balance right, but I think it's a risk issue not to have accurate guidance where the old guidance may be causing harm. So it's one of those things you have to accept, I think.
Thank you. We'll break there and I shall return at 3 o'clock.
All rise.
Ms. Hans.
I'm grateful, my lady. I have two distinct issues to deal with in terms of guidance, and then we'll be moving on to the next topic. Firstly, in relation to neonatal units, did the college have any role in developing or issuing guidance for neonatal units?
No, we didn't.
Thank you. And then in terms of the services following the guidance that was produced by both the College of Midwives and Obs and Gynae, there was a review by Embrace during the pandemic looking at women who died with COVID-19 during that period and found that only 1 in 10 who died were treated in accordance with the guidance developed by the two colleges. Did the Royal College of Midwives have evidence of that at the time and why that might be happening?
We didn't have evidence of that at the time. I think the guidance, it is guidance. We couldn't mandate the guidance. You know, NHS England would have to adopt the guidance. So the guidance to protect women, particularly black women who are more likely to have an adverse outcome and die, we were starting to be aware of that issue and therefore produce guidance, but it would need to be implemented by the NHS and by the government, not by the colleges.
Thank you. Moving on then to the categorisation of pregnant women as clinically vulnerable and the guidance in that respect. It's correct, isn't it, that the college were not consulted on that decision or given prior notice of that decision before it was announced in March 2020?
That's correct, and it was probably the thing that by not consulting with us, that expert team was unfortunate, because had we known that women were going to be classed as vulnerable, and the conversations then went to which gestation would they need to be isolating, we could have thought about mitigating some of the risks that then happen, particularly around pregnant healthcare workers. So we were surprised when that guidance came out without consultation with us, because I think by that time we had been recognised as an expert group that can give good and quick information to the NHS and the government. So I think that was really concerning.
And it's right, isn't it, that the college, along with the Royal College of Obs and Gynae, issued occupational health advice for employers and pregnant women during COVID-19 on the 26th of March 2020, which was again updated multiple times throughout the pandemic.
That's correct, but that wasn't really our place to do so. We had to do something to fill a gap to protect staff who were pregnant, particularly in healthcare, but in other services as well that were public-facing, because with the classification of women being a vulnerable group, and with then some data about some of those women then coming to harm, we felt that we needed to produce some guidance. It was complicated producing that guidance, and I think you'll find in my evidence that in the end we withdrew it and gave that responsibility completely back to the employer, to NHS England.
Yes, I wanted to ask you about that actually. Could you summarise that period in which there were communications with the government and public health bodies around the ownership of that guidance and the outcome of that?
I think it was the time where it was confused that the colleges have a responsibility to provide that guidance, and there was definitely an ask for us to produce it, own it and implement it, and that wasn't our role, and we made that really clear.
Why was it important to have it coming from the government or public health bodies? Because
we are not accountable for delivering services in the NHS. We are there to support our members to practice safely.
And did the chief nursing officers or midwifery officers get involved in advocating for that guidance to be provided by the government or NHS England or public health bodies?
Yes, they did in the end, and I think it was probably one of those occasions where the senior team in NHS England got involved.
And it's right, isn't it, that in fact the maternity team in the Department of Health and Social Care did take ownership of the guidance in October 2020?
They did. They took ownership eventually, which we were pleased about.
Do you know whether any action had been taken in Wales, Scotland or Northern Ireland in relation to this guidance?
I'm sorry, I don't know. We can get that information to you, though.
Thank you. The first guidance that is produced by the Department of Health and Social Care was published in December 2020. That removed the requirement that had been in the guidance from the colleges for women that were more than 28 weeks gestation to not work in public, in patient-facing roles, to move towards a more precautionary approach. Were the colleges consulted or did they advise on that guidance?
We weren't consulted, but we didn't approve. We didn't approve that guidance. We thought that would create an element of risk.
And did you seek to raise those issues?
Yes, we did.
What was the response?
I think. So my memory is that it was quite a confused response, which is one of the reasons why we withdrew our support for that guidance and said it was the responsibility of NHS England.
Did the college produce any guidance?
We did produce guidance. Yes, we did produce some additional guidance at that time.
Can you recall what the focus was of the college's guidance at that time?
The guidance was making sure that there was a local risk assessment for pregnant staff, that was done as part of the local occupational health risk assessments, that pregnant staff who had comorbidities or were more likely to be sick with COVID could then have the option not to work in a patient-facing environment, and that at 28 weeks that again staff would not be in a patient-facing environment. There was then an ongoing issue about how they would be paid if they weren't able to work, if there wasn't a suitable alternative employment for those staff. There was definitely an issue about whether they were on sick pay, whether they were on furlough, that maternity leave wouldn't be possible that early. So there was definitely some confusion about how those staff that couldn't work would be paid.
And it's right, isn't it, that a year later, so in December 2021, the college issued guidance alongside the Department of Health and Social Care, which moved the threshold from 28 weeks to 26 weeks gestation. Was there a change or development in the understanding of risk in that period of time that led to that change from 28 to 26 weeks?
I don't recall, I'm sorry.
Okay. Were you, the college, aware of any examples of issues around increased risk or misinterpretation of that guidance at the time?
There was some misinterpretation of that guidance. I think some of it was also about the fear that pregnant staff had, because there was some real issues about the environment they were working in and the lack of PPE. They were classed as a vulnerable group, and so working in a patient-facing environment, pregnant, even up to 28 weeks, was really concerning for staff.
In April 2020, the Department of Health and Social Care withdrew the guidance for employers in regard to pregnant women in healthcare settings. Do you know did you hear any evidence as to what impact that had?
It was in April 2022 that
Yes, sorry, did I say... My mistake, 2022.
In April, yes, the government withdrew the guidance, and we did oppose that because the legal requirement to risk assess, the infection risk to pregnant staff, because COVID was still around, was a key issue for our pregnant members, so we did oppose that.
I'd like to move on to a different topic now, and that's infection prevention and control measures in maternity settings. It's right, isn't it, that midwives expressed concerns around the PPE levels that were recommended in the PHE guidance early on in March 2020 as to whether that provided sufficient protection in the maternity setting. And that at the end of March 2020, the College of Midwives with the Royal College of Obs and Gynae produced guidance for healthcare workers in regard to use of PPE and risk assessments, and did refer to the PHE guidance. Was it the college's view that that guidance from PHE reflected the risks to healthcare professionals during labour and birth, and did it provide sufficient protection?
No, our view at the time was that it wasn't sufficient, that it was maternity. I think I've said earlier that maternity services often gets forgotten. It's not seen as an essential service, and our members told us that access to PPE was really difficult. That guidance did not protect them. By then, we knew that the COVID was spread through. It was an airborne virus, and what midwives told us was they were in a very small room with women in labour for many hours, and they felt at risk just being in just a normal mask, and that they believed that they should be treated the same as people in respiratory wards in an ITU and be fitted properly with an FFP3 mask. I personally had meetings also with some black midwives who were really concerned about not having access to PPE, knowing that the impact of COVID on that group of staff was higher. So there were a number of issues around PPE and availability, and how maternity services were not prioritised for the right PPE for the work that they were doing.
And did you raise those concerns?
Yes, we did.
What was the response?
The response at the time was about availability of PPE, which was that the FFP3 masks that and the fitting of them had to be prioritised for people who were in high-risk areas, so respiratory areas and known COVID patients. But that was not acceptable, so we did raise that we wanted maternity not to be treated as a separate service, that midwives were working in a very high-risk situation with women who potentially had COVID, and they were therefore at risk. The other thing about, just linking back to what you said before about healthcare workers who are pregnant, maternity is largely a female workforce, and we seem to have more pregnant midwives and maternity support workers than any other group. So there was another consideration that a lot of people were working without appropriate PPE, with the wrong guidance in maternity services, and therefore that the impact of that on them was considerable, and we heard a lot about that.
And what about PPE, in particular the wearing of masks for pregnant women, particularly during labour? What was the college's view on that, and did it change at all during the pandemic? It
did change. We did change that view because women really struggled to be in labour with a mask on, so the requirement to wear them. The risk assessment about not wearing a mask was then undertaken. Midwives also found it difficult to wear a mask to be able to communicate well with women, particularly in labour. So I think everybody struggled with it, but ultimately it was about being safe.
And later on in the pandemic, in February 2021, it's right that the college signed a joint letter to Boris Johnson, copied to Matt Hancock, requesting a change in approach in the IPC guidance and advice on the use of PPE to reflect the airborne risks in healthcare settings. Is that right? That's
correct. And that letter was a joint letter with our TUC colleagues, because obviously we're also a trade union representing the safety of staff. It went to Boris Johnson because we were frustrated in terms of the lack of action and that attention on proper PPE guidance and access to the equipment.
And in terms of maternity settings and the role of the college in particular, did that lead to any changes or further conversations?
Yes, it did, and we had feedback from our members that things then started to improve, which was a good thing. I think there was then issues in the next wave of the pandemic, but certainly at that point things did get a bit better.
And it's right, isn't it, that in June 2021, the college also met with the Department of Health and Social Care and others to discuss IPC guidance further. What was discussed specifically at that meeting, and again, did that lead to any changes? There
were some training, but there was some changes, but it was about quite a lot of it was about the training in the use of protective equipment, because I think maternity again had been left out in terms of the training and how it could be used effectively. There was also an issue about community staff. I'm not sure if that's picked up here, because obviously midwives were working in the community setting, not just in hospitals, and PPE and the training and the use of it in the community setting was again a massive issue which was brought up, and I think it was around the same time.
And the community setting in the maternity settings, would that be around health visiting and those kind of settings? No,
it's community midwives who have local clinics, face-to-face clinics, but also visiting women in their own home. And they really struggled to access appropriate PPE. And they were a group that were particularly anxious because quite often they go into a home where there were lots of people, maybe in an unventilated environment, and they felt particularly at risk.
And in terms of testing, was the college aware of any issues with maternity staff accessing testing during the pandemic?
Yes, when testing came in, I think maternity again was one of those areas that wasn't at the top of the list. I can understand that, but it was again our plea to make sure that maternity was seen as an essential service and therefore needed to be treated in the same way, because the potential for really poor outcomes for women due to the pandemic, but also the impact on staff not being able to work was considerable, because nobody else can look after those women other than the midwives. And that was it was really important that availability of tests should have been a priority within NHS services.
You spoke briefly earlier on around some of the unique issues with maternity units with what's known as cohorting of patients. Can you expand on what some of the issues were in hospitals and maternity units with cohorting of pregnant women, depending on whether they had or were suspected of having COVID-19?
It was really difficult for some services because they didn't have the right environments to safely cohort women, COVID or no COVID. It caused considerable problems. It was also difficult before testing, because unless women had COVID symptoms, quite often staff didn't know whether they had COVID or not. So that was difficult. I think it caused anxiety this is my personal view. I think it caused anxiety for the staff as well, without the right PPE, then caring for women who were in an area where they were known to have COVID, and it made them feel very vulnerable.
Thank you. Moving on to inequalities. Firstly, in the guidance for pregnant women, there was evidence of the significant disparities in maternal outcomes for ethnic minority women known prior to the pandemic from a number of reports. And in May 2020, the Royal College of Midwives issued guidance to reflect the increased risk to ethnic minority women in respect of COVID-19. Can you briefly summarise that guidance and whether there were any challenges in communicating those risks to ethnic minority pregnant women?
Yes, so our guidance was to our members, so guidance, we couldn't mandate it, to prioritise women from BAME groups, to help them understand how important it was to access maternity services, but also for staff to prioritise the care of those women as well. So extra visiting, I think I said earlier, extra visiting, extra support, that was really key. Obviously, the information did come out eventually from the NHS that they were a significant group to prioritise, and there was some very clear guidance about access those women, being able to go into the communities to talk about the importance of being able to access maternity care, and not to worry. I think women were worried. They were worried when they could see that the death rates were higher. For that group of women, they were anxious about going into hospital and accessing maternity care, which I think in some cases probably created a poorer outcome. So there was definitely a concerted effort by us and by everybody to try and engage that group of women. It also impacted on the staff, because there's a significant number of staff from BAME backgrounds working in maternity services who were also really concerned about their exposure to the virus, and we know that the death rate for them was higher across the NHS than for white midwives.
And the college issued guidance for employers to consider risks for ethnic minority staff when reorganising services as well, didn't it?
Yes, we did. And some of those we asked for them to not be patient-facing, particularly not patient-facing with known COVID women. That again created problems in areas where there was a high number of BAME staff, because it depleted the staff even further in terms of being able to provide face-to-face care.
And this may be the guidance that you were just referring to, but in June 2020, NHS England announced additional support for pregnant ethnic minority women, known as the 4 common sense steps.
Yes, that's right.
Yes, and it's correct, isn't it, that the college agreed and endorsed those principles. Was there any monitoring of the effectiveness of those interventions? You're aware of?
I think we didn't, but I think NHS England did, and I'm aware that they did check that services were implementing them. So I think there was an evaluation, but I'm at the moment I'm not aware of what the outcome was.
I think you said in your statement that little progress had been made since the publication of the 4-step action plan. So looking back, do you think there could have been further action taken at the time to try and mitigate the differences in outcomes earlier on?
Yes, but I think it was again about having clear and focused communication about the things that were going to improve outcomes. So it would be about, I think it did make some difference in some areas, and certainly some of the staff that I spoke to were really pleased to see that guidance and that focus. But again, it's the how in the pandemic was there focused communication, a single point of the truth, so that staff and women knew what was the best thing to do.
I think it's right, isn't it, that there was a ministerial roundtable in July 2020, which the Royal College presented findings and recommendations to address the maternal disparities. And you've said in your statement it wasn't particularly useful, and government were reluctant to engage. Why was that, and what would have made the government's engagement more effective at that point?
I think at that time the impact of the poorer outcomes was not necessarily really understood, although we'd seen the data. So it was about prioritising again maternity services amongst all the other NHS services that are being delivered. So, we wanted maternity services to have a higher profile. We particularly wanted those women that were more likely to have a poorer outcome to have a higher profile, and for there to be a focus on them and clearer support and communication for staff to deliver different services to that group of women.
And in terms of risk assessments, I think a survey that the college undertook found that in September 2020, only 23% of trusts had conducted risk assessments for ethnic minority staff and patient-facing roles. Were you aware of whether that improved, and if so, when, and whether any additional steps that could have been taken to support that being undertaken?
That was an improvement on where it had been before, because previous to that there was no risk assessment, so 23% was going in the right direction. So it was definitely about making sure that services saw that as that risk assessment as a priority. But there were lots of priorities, and it was very difficult for some of the staff to see that as the priority at that time. During the pandemic, NHS England continued to implement some policy changes, some service delivery changes. So there was a lot going on. So, for example, midwifery continuity of care was continued to be implemented, and our view was that we had to help services and NHS England to focus on the things that were going to make a bigger difference to the outcomes for women.
Could you slow down again?
Sorry.
Moving on to the topic of mental health and wellbeing support for maternity staff. Can you briefly summarise the impact on midwifery staff of the restrictions that were in place during the pandemic and any support that the college provided to its members?
Okay, so the members told us there was significant impact on their mental health. Primarily midwives, maternity support workers and all the whole maternity team wanted to provide a high quality of care, safe care, choice for women, as they always did. They were very anxious and stressed not being able to do that, and disappointing and upsetting the women in their care. So that caused distress in itself. Then the not prioritising of maternity services, then women being classed as vulnerable, and then poor access to PPE, having to make really difficult decisions about not being able to provide home births, for example, for women who really wanted them. The lack of confusion around visiting and the tension that created between the women, the partners and the staff, all of that contributed to a much, much higher level of stress and anxiety than you would normally see in a maternity staff group. There was support in some services for staff to access help for their mental health. We also have local field staff. So our branches are in the field, and we really encourage them to support staff in terms of accessing support locally if they were feeling very stressed and vulnerable at work. I believe that it had an impact on staff's ability to keep going and to keep thinking about doing their best. I think staff told us that they just about managed to get through day by day. Some staff didn't, and either left the profession, left their job, or went on long-term sick. And on top of that, of course, COVID and long COVID and all the other things. So I would say that staff, tried their very, very best. And it had a personal toll on their health and their mental health, which I think they're still recovering from. I don't think it's over. I think it is impacted on midwives wanting to stay in the profession.
On the topic of long COVID, are you aware of the impact it's had on the profession?
Yes, we have a number of members who have long COVID, and how difficult they found that, particularly when they think that they got COVID because of lack of PPE and poor environments in their workplace. And I'm certainly aware of members that are very clear that has happened to them.
Has the college provided any support to those members or signposted them to support?
Yes, absolutely, and we would see that as part of our role.
Could you provide a couple of examples of that support?
So, for example, we had a member, actually, she's been on television recently talking about her COVID and long COVID experience. She had support in the workplace and other members have had support in the workplace to negotiate working in different ways, also to maybe have a longer period off sick, to have phased return to work, not to work in a difficult clinical environment. So, there's a number of things that we've been able to do for those members.
Thank you. Ms. Wharton, you've very helpfully set out a number of key lessons to be learnt in your statement. I wonder if there are any that you haven't already covered today that you wanted to pick out to bring to our attention to ensure that maternity services are better prepared to support pregnant women in a future pandemic.
I think ultimately is that maternity services are seen as an essential service. Getting it wrong in maternity services is unacceptable. The service went into the pandemic in most of the countries without the right number of staff or appropriate environments. I believe that it's important that women's voices and the voices of the staff who are looking after them can be heard, that they are able to be heard at every level of the system and to government. You know, this is primarily a women's service delivered by women. You know, I think it's really important that those voices are heard and collective voices are heard. I think my key message is that the colleges very quickly came together and had a huge number of experts that could produce support and guidance, that if we all worked together, we could have had a single version of the truth that could be produced quickly and maybe prevented some of the inconsistencies and anxiety that then was created. I think if we were to go into another pandemic, I think you said it earlier, what could be done before? You know, what things would we think about in terms of, for example, prioritising provision of community services? How could that still be provided, but particularly when there's a reduced number of staff? What could be done differently to predict, have a toolkit for predicting where staff needs to be to deliver safe care? And that could be communicated even at the beginning of a pandemic and not halfway through it. So everybody knew, the women and the staff knew what could happen if, for example, there was only half the number of staff available, what services then could be safely delivered. I think that would be really helpful.
Thank you. I have no further questions, Madam.
Just before I turn to Mr Wagner, who I know has some questions, at the risk of being too controversial, you've said several times that maternity services are not considered an essential services, they're not getting the priority or the profile they deserve. And you've also said, obviously, it's a service basically run by women for women. Do you think there's anything between cause and effect, the fact that it's a service run by women for women and the lack of priority?
I think potentially yes, and I think, you know, women's services in the NHS don't get the right attention, and maternity is part of that. I think, you know, it's been seen for a long time as women having babies. Actually, if women having babies, if we don't get it right, it can very quickly go wrong. And the outcomes, which I know you will have heard of, are absolutely devastating for the families. So I absolutely believe that getting it right at the start of life, having maternity services prioritised in the NHS is the right thing to do. And actually it's an investment in the future health of the population.
Well, also, and if things go wrong and a baby ends up born brain damaged and it's because somebody in the NHS hasn't done their job properly, then that can be extraordinarily expensive for the NHS.
It's one of the most expensive insurance claims, actually, in the NHS. So, you know, getting it right is so important. And that's what our members want. They say that all the time.
Do we have any evidence as to whether or not the fact it's women services run by women for women to suggest that that's why it doesn't get the priority it deserves? Or is it just a feeling that you and I may share?
I think there is some evidence. There is definitely some evidence because quite often in an organisation, midwives don't have access to the decision makers as often as they should. So I think that there is some evidence of that, and that's a short answer from probably a very complex issue.
I do understand that. Mr Wagner.
Thank you. Good afternoon. I ask questions on behalf of the 13 pregnancy, baby and parenting organisations, and I've no doubt that they would agree with the sentiment of that final passage of question and answer. You've given very clear evidence this afternoon about the huge anxiety amongst staff and parents caused by inconsistent and poorly communicated guidance. And is it right that the RCM were already raising concerns about that in relation to the visiting guidance to the NHS by June 2020, and this relates to those emails that are referred to at paragraph 38 of your statement.
Yeah.
And then, is it fair to say that over the summer of 2020, in facing that lack of guidance, the RCM, the Royal College of Obstetricians and Gynecologists, and the Society of and College of Radiographers stepped into the breach and developed that framework agreement to support the reintroduction of visitors in maternity settings?
Yes, we did, yeah.
Yeah. And that was endorsed. It was later, sort of a month later, endorsed and disseminated by the NHS. But were they involved in the drafting, or was it a document that was presented to them for their approval?
They would have been involved. Sorry, I don't know for sure, but they were. We did communicate with NHS team regularly. Quite a lot of the guidance we produced very quickly, and we'll have done it in consultation with the people we were working with. Some of those were women and families as well, and other organisations. It was really difficult to come up with the common sense approach in terms of protecting women and families, in terms of the virus and the spread of the virus, and the staff who were caring for those women in very difficult environments. Sonography, I think you mentioned, was definitely a group of staff that were really concerned of, because a lot of the sonography rooms in maternity services have no ventilation and are really, really small. So there was a huge risk there, and it was about how did we help with guidance that was going to be a common sense approach and allow and encourage people to do those local risk assessments, but with some guidance from the NHS.
Yeah, and you said in your oral evidence that we, the RCM, are not accountable for delivering services in the NHS. We're there to support our members and practice safely. So would it be fair to say that the guidance that you were producing or helping to produce was coming from that perspective?
Absolutely. We're a membership organisation. So, we are there to, as both a trade union and a professional association, to support our members, to be safe in practice and at work, but also to deliver safe care. They then deliver safe care to women and families. So we absolutely were there to make sure that we were the voice of our members, both locally, but also to the government and the NHS. That is absolutely our role.
Yeah. And you were asked earlier by Ms. Hans whether any consideration was given to consulting with patient representative groups during the development of guidance, but I wasn't clear, and I'm sorry if I missed it, whether you then said yes, it would have been, but I didn't know whether you were talking about the July guidance or the December guidance.
Okay, so the COVID, the cell that was the COVID cell, which was the joint guideline group with the RCM and the RCOG, had patient representatives as part of that. Also, we regularly talked to parent organisations, for example, the NCT, and we had a group called One Voice, which was all of those organisations together talking about key issues. We absolutely had those conversations, but ultimately it was about us providing support and guidance for our members. But we would also encourage, and I think I said this earlier, local services to discuss guidance, changes to services, and anything that they were going to do differently with their local women's groups, so the Maternity Voices partnerships, and they're different in the other countries, but with the local groups of women, that was really important, and we did encourage that.
In relation to the December guidance, the December 2020 guidance, this is moving on to a national guidance by the NHS. It's not the same structure as the previous guidance that was developed by the trade unions with the NHS. Is that fair?
Yes, that's right.
Yeah, and in relation to that guidance, is it right that the RCM and the RCOG raised concerns about the guidance imposing, in its initial draft, mandatory requirements for trusts to facilitate women's access to support at all times during her maternity journey, and your comment was that should be not mandatory but non-mandatory.
That's correct, because at the time that guidance was finally produced, the infection rates were increasing again, and so there was definitely a risk to increasing the number of people who had access to maternity facilities. So there was a huge concern about then increasing infection rates amongst women, babies, the staff. Different environments, I think I said this before, different environments lent itself really well to partners being able to have access throughout the whole labour journey, because they're single rooms and it was easy to then have people cohorted in one room. It became really difficult for partners to then be in all parts of maternity services where the environments didn't facilitate appropriate social distancing. I know that midwives found all of that really difficult. They absolutely believe that both parents should be there, if they want to, across the whole journey of pregnancy, birth and beyond. That absolutely is key. So it's one of the things that I think midwives struggled with, being able to do what they believe was the right thing for parents, but also to keep everybody safe. And that's why in December we were really concerned about the continued opening up guidance rather than the local risk assessment.
Do you accept, looking back, that one consequence of that guidance ending up giving individual trusts that latitude rather than mandating certain visitors being allowed into the room? Do you agree that would have led to continued inconsistency and unpredictability between different trusts?
It did, but that was it was going to happen because different maternity environments are not suitable for providing safe maternity care, particularly in a pandemic. But if it was one size fits all, which I think NHS England wanted, that would then expose risks. The problem was, and I think I mentioned about social media, then different services, women had different experiences in different services, and so those that had their partners and others, with them throughout the whole experience would say, I've had the best care ever, this is what my service allows. And then other people got really disappointed and upset because the service they accessed couldn't do that. I'm not sure what the answer is to that, other than make sure that women's services are the best, that the environment is perfect for now and for a next pandemic. Because I do believe that women and their partners should have had equal access to maternity services together, but it just wasn't safe to do so in every single service across the UK.
Do you also agree that if this inconsistency and confusion was going to continue, that would necessarily mean that the anxiety amongst people using the services that you complained about, I don't say you complained about, but the RCN complained about in June 2020, would persist during the later period?
Because the pandemic was, during the whole time of the pandemic, more and more information and almost a trying out of different approaches was happening all the time. I think sometimes services tried something and then realised it didn't work and had to change their approach. And I think it should be commended, some of that flexibility, with always in the top of their minds keeping everybody as safe as they could. I think right at the beginning of the pandemic, I think you're right, very clear advice when we really didn't know what we were dealing with was really important. But as more information came in, how could those local risk assessments happen but continue to be in a safe way. I think, way in November, December, where the whole opening up of maternity services was actually going to create a risk was of real concern. So it was about how could it be localised but still have some very clear principles of keeping people safe, because all the environments were so different. There was also the issue, of course, of home environments and midwives working in a community where, again, that caused considerable concern about exposure to the virus.
Just finally on the RCN not endorsing the guidance in December 2020. In your view, did the fact that you didn't endorse the guidance impact on how widely it was disseminated and how well it was ultimately understood by the frontline professionals?
I'm not sure about that, but I would say that we didn't endorse it because we were primarily concerned about the safety of the staff and the women and family that they were caring for. And as the infection rates were growing and we were moving again into another lockdown, it seemed like that was moving in the wrong direction in terms of keeping everybody safe.
Okay. Thank you.
Thank you, Mr. Wagner. Thank you very much indeed, Ms. Walton. Really grateful to you. Sorry if we kept you here for a long stint this afternoon.
That's okay.
What we can say is that other people do get even longer stints. But I'm very grateful for your help.
Thank you.
Very well. I think that completes the evidence for today, and I shall return to sit at 10 o'clock tomorrow morning.
All rise.